And get started. Welcome to the Grand Rounds for the Department of Internal Medicine. Today is sponsored by the Division of Cardiology. We're going to hear from Dr. Makkiya about hypertrophic cardiomyopathy. So to introduce our speaker, we'll just go ahead and get started right away. We'll welcome Dr. Fadi Saloom up to introduce our speaker. Thank you all.
All right. Good afternoon, everyone. It is truly my pleasure to introduce my colleague and friend, Dr. Makkiya, who is an assistant professor of medicine in the Division of Cardiology. And he also serves as the medical director of the Hypertrophic Cardiomyopathy program, which interestingly, he established at the VCU Pauly Heart Center a few years ago. He completed his internal medicine residency at Montefiore Medical Center, Albert Einstein College of Medicine in New York, followed by fellowship in general cardiology, as well as advanced cardiac imaging. His research interest is in hypertrophic cardiomyopathy in both inpatient and outpatient settings, including cohort studies and clinical trials. Dr. Makkiya is a member of the American College of Cardiology, American Society of Echocardiography, and the Society for Cardiovascular Magnetic Resonance, to name a few. He has contributed to editorial activities of peer-reviewed journals, including Vascular Journal and Clinical Imaging. He was the recipient of the Best Case Award of the Month for the American Society of Echocardiography in 2019. He has contributed several publications to the field and is currently a site PI for the Odyssey HCM trial to study mavacamten in non-obstructive hypertrophic cardiomyopathy. Dr. Makkiya has been described as an innovator focused on care, collaboration, and bringing attention to a rarely diagnosed condition. We are truly fortunate to have him on our team here at VCU. Please join me in welcoming Dr. Makkiya. Walking.
Thank you, Dr. Saloom, for your kind introduction. My name is Makkiya. I'm a non-invasive cardiologist, and I do cardiac imaging and interested in hypertrophic cardiomyopathy and run the program here. So to begin, I have no disclosure to this talk. So if we're going to talk about like some history of hypertrophic cardiomyopathy, then we go into epidemiology, definition per the recent guideline, some basic genetics, and then clinical manifestation and complications and new advances in the field, as this is very active field right away, and you're going to see a lot of these patients coming into your clinic. So first of all, I like to show this slide about history of hypertrophic cardiomyopathy. This was first described by Dr. Donner Tier 70 years ago. He was a pathologist and the coroner of London back in the 50s. And in 57, he did an autopsy series, which he published here, describing accurately to this date, which is fascinating, hypertrophic cardiomyopathy. He described it as a heart muscle thickening. And we see on the right-hand side picture, there is like this disorganized myocytes with a lot of interstitial tissue, the so-called myocardial disarray. At the beginning, he thought that this is like a cardiac tumor. But as we advance and we become more knowledgeable of the disease, we knew now it's a mostly genetic condition or sarcomeric issue that leads to late LV hypertrophy. It has several names throughout the history, from idiopathic hypertrophic cardiomyopathy to subaortic stenosis to hypertrophic obstructive cardiomyopathy. Now the general naming for it is sarcomeric hypertrophic cardiomyopathy. So to go into pathophysiology of this, it's usually inherited in an autosomal dominant fashion. So 50% chance giving it to your offsprings, basically. And this involves mutation that affects the sarcomere. It's involved about 11 genes that code for the thick and thin myofilaments of the cardiac sarcomere. And basically what happened, you will have a lot of actin and myosin interaction and cross bridges formation than a normal myocardium. And this will usually typically result in the thickening and the hypercontractility function that can happen, or hyper EF that can happen with hypertrophy. This is important because the newer medication target that feature, which we're going to talk about later on. So I'm showing a pathophysiology or histopathology slide of, in picture A, we have a normal myocardium histopathology, where you see the myocyte is very nicely organized parallel to each other, and you have less white space between them, which means less interstitial tissue. Versus in hypertrophic cardiomyopathy patients, as we see in picture B, where you see like the myocytes are very disorganized. There's a lot of white space between them, a lot of interstitial tissue. I call it like the starry sky picture by Van Gogh. And in C, it's more as of a zoom picture. So that's pathognomonic for HCM when you do biopsies on these patients. And then talk about the history of the field, how it's advanced, the imaging advanced. It's mostly like, it's a combination of diagnosis of like many things to come to the diagnosis, but imaging is a cornerstone of that. So we started knowing it in the late 1950s, and then we started diagnosing that by doing angiograms in the 60s. Then in the 70s, we started to have M-mode echo. And then in the 1980s, we started doing we started having the 2D echocardiogram when we started seeing the HCM and assessing the thickness. Then comes the first generation MRIs, which really changed the field in 2005. And we used to do these without contrast, without gadolinium. But we can really see and describe the LV geometry, dimension, and phenotypes of HCM. And then the second generation of MRI came in 2010. And that when we started using more and more contrast for these patients, and that added a lot to diagnosis, to differentiate mimickers of hypertrophic cardiomyopathy, and has a big prognostic value. Another this is a big slide, but to summarize it, it describes the timeline or advancing in the field, which is now it's really, really blossoming and advancing quickly as we have new therapies. In the 1960s to 70s, that's first when we started treating it with beta blockers, and myectomy was introduced at Cleveland Clinic. That the first myectomy was performed. And then in the 80s to 90s, we started doing echoes, and family screening was started back then. In the 1999, we started the first HCM society or association, basically, where they tried to do establish more centers for HCM. Then the MRIs and invasive septal therapies and all of that came in the 90s to early 2000. The first guideline came in 2014. And now it's updated in 2020, and this is going to be updated within the next year or two because the therapies are getting introduced very quickly. Now we just started the HCM Society meetings, which is an annual meeting we're doing, started last year. And we have 2 meetings, very big meetings, successful meeting that is expanding, like the Heart Failure Society meeting. Because of, again, we have newer disease-modifying agents, newer therapies, gene therapies may be coming in the future for that. And we are doing a lot of studies that VCU is currently sized for that. So some epidemiology. This slide shows in red color the areas in the world that people have HCM. And what we get from that, this is worldwide. It's about in 122 countries, about 90% of world population, they have it with a prevalence of 1 case to 200 to 50%, basically estimated about 20 millions. So what you need to get from this, that this is worldwide, okay? And on the picture B, we can see that 90% goes not recognized, okay? Only about 10 to 20% is recognized. So it's very well not diagnosed or not recognizable disease. And that stems from many things, okay? The reason for that, lack of knowledge, lack of advanced imaging technologies, which usually make the diagnosis, family screening, gene testing, all of that contribute to that, okay? Again, in this study, or different studies from all over the world, where they checked prevalence of the disease, and they got the same numbers, one in about 200 to 500 patients from US, from Africa, from Asia, and you get same numbers. So it has the same prevalence everywhere. So it's a common disease, but usually missed. Another study that shows that when we now doing more cardiac MRIs, more advanced studies, more gene testing, more family screening, this incidence has increased, or prevalence has increased from 0.2% to 0.6%. So that's roughly 1 in 200 patients. So really what I'm showing here that this can be a very common disease, and you guys at the front of seeing these patients. So we need really and this can be like really has a lot of complications that we're going to talk about that if we don't do anything about it can result in bad prognosis. So what is the definition of HCM? This comes from the recent ACC/AHA guidelines, which define HCM as a maximal end diastolic wall thickness of more than 15 millimeter or more in the absence of other things may cause it. Basically hypertension, athlete's heart, aortic valve stenosis, or infiltrative cardiomyopathy, okay? We use echocardiogram or MRI to make that determination, and also it has other things that can help us to guide the diagnosis. For children or young children, we don't use that definition particularly. We adjust that to the body size and growth, and a body surface area adjusted Z-score of 2 standard deviation above the mean, usually coincide with hypertrophy. Now for screening families, if the father or the mother have genetic hypertrophic cardiomyopathy, that definition we will define them as they having hypertrophic cardiomyopathy when the septal wall thickness is about more than 1.2 centimeters. So we are more aggressive of defining hypertrophic cardiomyopathy in patients who have positive gene therapy, positive gene testing for hypertrophy from their parents. And in this slide, we see the different morphologies of hypertrophic cardiomyopathy. The most common one is sigmoidal, where you have most of your thickness in the septum or the base of the septum of the heart. And that's about 50% of HCM cases everywhere. Unfortunately, 2 things for this. Hypertension can cause this, or just being elderly, it's part of the remodeling process for geriatric patients. They will get this basal septal or sigmoidal hypertrophy, and only 10% of these patients they will test gene positive, even if they have the phenotype. Okay. The next common one is the reverse curve, where you have most of your thickness is in the mid septum. Okay, and this one is the most one to cause positive gene testing. About 80% they will have that. You have the apical HCM, where most of your thickness is in the apex of the heart, and that's kind of like about 10% of the cases, and the least one to cause symptoms because it's far away from your blood flow. Okay, and then the neutral, when it's concentric, everything is enlarged equally. And this is also about 10% of HCM. So knowing phenotype also will help in determining the treatment and prognosis down the road. So how we diagnose HCM? It's a diagnosis of, it's a whole package. You need to look at the clinical picture, the symptoms, the family history. Then we can use EKGs. We start with EKGs. Imaging studies is the cornerstone of diagnosis. Multimodality imaging. Gene testing can help, not all the time. I'll tell you why in a second. And then biopsy. We don't do a lot of biopsies, only for cases that we are really, really not sure, and we suspect there's something else like infiltrative cardiomyopathy doing that. But it's mainly imaging studies, a combination of the clinical picture, EKG, and gene testing. So EKG. what do we see in the EKG? We see hypertrophy, basically. It's quite specific and fairly sensitive test to detect hypertrophy if you do it right. So how do we define hypertrophy or LVH in EKG? We use different criteria in cardiology. Cornell, which is the most widely used one, when you have AVR and V3, AVR R wave and V3 S wave more than 28 millimeter, or the modified Cornell when your AVR is more than 10 or 12 millimeter in amplitude. And then the Sokolov-Lyon, where you have V5, V6 R wave and V1 S wave more than 35 millimeters. And then you have this Estes point system where you have different points. If you have it on your EKG, can tell you have LVH, but it's mostly the Cornell and modified Cornell. These are the easiest one to look at. Okay, and EKG can be sensitive up to 70% in detecting LVH. Things can lower the sensitivities, being obese, improper placement of the leads, or if you have something that dampened the leads, like effusions and all of that. COPD, for example. Another distinct EKG, which we can see in hypertrophic cardiomyopathy, is this LVH with deep T-wave inversion, very scary T-wave inversions in the mostly anterior anterolateral lead, as we see in this EKG. And this we see in patients who have apical hypertrophic cardiomyopathy, or they may develop, or people who have apical aneurysm. And that's one of the things that we look at in diagnosis these patients. Of course, you should keep in mind the differentials for this deep T-wave inversions, which is acute anterior myocardial ischemia and ACS. You can see that post-pacing. You can see that post-tachyarrhythmia recoveries, or in cerebral diseases like brain bleed or strokes. So we switch to imaging, which is the most important tools that we have in diagnosing the disease. We usually start with echocardiograms, and echocardiograms are readily available, cheap. Now we can have them in our pocket, the handheld ones. You just put it in your pocket and attach it to your iPhone or Android, and you can look for LV hypertrophy. We can also use tools in echo to help us to measure obstruction, which I'll show you what that means in a second, by using Doppler methods. Also, we can evaluate associated valvular condition like mitral regurgitation that commonly happens with it. Also, it helps us in guiding the management or tailoring the management for these for this condition. And sometimes if we have patients who are symptom or equivocal in their symptoms, we can do a stress test to tease out these symptoms. So we stress them, take pictures, echo pictures to see if they develop obstruction with the stress. Also has important, it gives us important information about risk assessment for tachyarrhythmia, sudden cardiac death, and prognostic value. And we use it to screen family members, which is also important in these patients. And then by planning invasive septal therapies. So in echo, it also, the benefit of the echo, it shows us the different phenotypes, and also evaluating for obstruction, which we see here in the picture. What does obstruction mean? And that's the major cause for patient symptoms in hypertrophic cardiomyopathy. It's where the blood leaves the heart. It struggles as it leaves the heart because of obstruction at the LVOT before it reaches to the aorta. And it's usually a combination of the thickening and problem with the anterior leaflet of the mitral valve. It's more elongated and get pushed in systole toward the LVOT with the thickening of the basal septum. It makes the LVOT narrow. So imagine if you're like you're watering your garden and you're holding your hose, and if you put your finger in it, it's gonna be speedier. You're gonna make it small, the diameter, so it's gonna be speedier. And we can detect that the speedier the flow is in there, the more is the obstruction. We call it the Doppler velocity for that. And echo is important in showing us that. It also shows us it has prognostic value by evaluating the EF or the systolic function. People usually with hypertrophic cardiomyopathy, they live at a high systolic function, 70% and above. And we call advanced heart failure, like in any regular heart failure where the EF drop less than 50. So we have a high bar we set for EF in patients who have hypertrophic cardiomyopathy. We can also see apical aneurysms and apical clots that can happen with apical hypertrophy. Then comes the MRI. As echo is the workhorse for diagnosing HCM, but MRI is the gold standard. And the reason is, MRI, you have a much better spatial resolution and contrast resolution than echocardiogram. And that means you can see nicely here, there is a big contrast between the LV cavity and the LV muscle. So you can really measure the muscle accurately. You can see and check the function very accurately. It's like watching a movie in an Ultra HD TV versus SD TV that like we used in the past of the heart, basically. It's very important in evaluating different phenotypes of HCM, the one I showed you earlier, because of the good quality pictures. We can also assess things can happen with HCM, like abnormal papillary muscles get thicker or insert in a wrong way, not directly into the valve or sometimes into LVOT, or the mitral valve gets very elongated with this. This also helps our surgeon when we do myectomies on them and planning the surgery. If they need to fix the mitral valve, if they need to fix the papillary muscle, MRI can really, really help with that. It's a better way in detecting things that we usually don't detect very well in echo, like apical aneurysm or focal hypertrophic cardiomyopathy, and it has a significant prognostic values that I'm going to talk about in a second. Also, this slide showing the difference can be from echo and MRI. Sometimes we have entity of hypertrophic cardiomyopathy that is, or consider it as a phenotype. It's focal. It affects one segment of the heart muscle, like in these two pictures in AB and EF. Echo can miss these parts, especially the anterolateral or infraseptal parts of the heart. And you cannot really, you can misdiagnose or underdiagnose HCM if you don't do MRI, like clearly it shows it in here and it's significantly thickened. Also, echo can miss apical HCM because the quality is not that good. MRI can really show that. So we talked about diagnosis. So the focus of diagnosis, as I said, clinical picture, EKG as a start, then echo. And if you really think there's hypertrophy, definitely send for cardiac MRI. So genetics, this is a genetic disease inherited in autosomal dominant fashion. Okay, it affects the thick and thin myofilaments. About 11 genes causes that of the sarcomere, or most of them, 50 of them, is affecting the thick myofilament proteins of the Z disc, basically. One thing to tell you about gene testing or genetic testing, it's not gonna, even if you have the disease phenotype, if you have genetic, you think the patient has genetic HCM based on the whole picture or diagnosis that we did earlier, about 60 to 70% of the time, they will test positive for the gene. And there is a reason for that, many reasons actually for that. The genetic field in HCM or any cardiomyopathies is still evolving. To call a gene pathognomonic, you have a series of checklists that you have to, that the gene has to have to call it pathognomonic. And of course, the more, this is going to change in the future. More people is going to do gene testing because now it's becoming more available. We do it at our clinic for free, even we don't charge the insurance. And if you have a patient who's positive, 2 of their family members, they get tested for free. So we're going to have a big database for that. And we may reclassify genes like a positiveness. Okay. Important concepts to know about gene testing. If you have a specific gene of your gene mutation, if you're gene positive, that doesn't really gives us information about the extent or the phenotype of HCM. It doesn't tell us if these people gonna have worse prognosis or better prognosis much, basically. And now the utility is mostly confirmed to screening family members, sometimes it can help us in the diagnosis. So if I have ambiguous cases, I don't know, this is HCM, genetic, this is hypertension, I can do a gene test. And if it's positive, I can say, no, this is most likely HCM, okay? Very important concepts is the variable penetrance and variable expression of the genes. And what does that mean? What's variable penetrance? That means if two family members with the same gene mutation, they can have the disease or they may not have. So if somebody has the disease and another person in the same family has the gene, they may not necessarily develop the disease. The penetrance is different. And what is the variable expression? If the two family members have the disease, they may not have the same disease in regard to the phenotype or aggressiveness. That's an example for that. So here I'm showing you a case that was published where the proband, the father, has one of the positive genes for hypertrophic cardiomyopathy, MYBPC. That's the most common gene to get positive for. And he has sigmoidal hypertrophy, okay? Then he has 4 children, 2 sons and 2 daughters. One son did not develop the disease, the gene, so he's off the hook. We don't need to monitor them. We don't need to test their kids, basically. The other son has the disease, but he had different phenotype. He has the reverse curve. One of the daughter who tested positive for the genes has the apical phenotype. And the other daughter has the gene, but till now never developed the disease. We keep an eye on them. Okay, so the penetrance and expression can be variable. So as the aggressiveness, you may have a least aggressive disease in the father, but more aggressive in the children and vice versa. So family screening, before I go to the next slide, is very important because many things we can prevent in screening the families. And the reason for that, which I'm going to show in the next slide, based on the clinical course and complication that can happen from this disease or this pathology. So what are the symptoms to have if you have hypertrophic cardiomyopathy? I would say about 50% of the time, you won't have any symptoms or very mild symptoms. People just don't know it, okay? Especially if they are young. And this can be diagnosed incidentally, like you're doing for a pre-op and you send them to do an echo, and you in the echo, he has a hypertrophy and it starts the whole treatment. But if they are symptomatic and they may have symptoms of heart failure, dyspnea on exertion, fatigue with exertion, some chest pain with exertion from microvascular angina, not epicardial coronary artery disease, symptoms from arrhythmias, palpitations, dizziness, passing out. So these, what I'm trying to say, these symptoms are not unique. It's not like it can be fine. We can have the same symptoms in other forms of heart disease, like heart failures or arrhythmias in general, coronary artery disease. So just based on the symptoms, we cannot really tell or diagnose hypertrophic cardiomyopathy. It's a whole picture. In this slide, as I said, 50% will go with no symptoms or very, very mild symptoms. And that makes the disease diagnosis is difficult. And about 40 to 50% will develop symptoms or complications related to the disease. 40% is heart failure symptoms from obstructive and non-obstructive pathology, which I'm going to tell you what that mean in a second. 70% will have atrial fibrillation and symptoms related to atrial fibrillation, like palpitations. These people usually don't tolerate AFib. If you have patients who have HCM and keep having AFib, they don't tolerate it very well and they become very symptomatic from it. Stroke complications related to AFib, paralysis that leads to mortality. And 6% will have sudden cardiac death event. 6%, very high number. We'll come to that in a sec, okay? So if you have heart failure symptoms, dyspnea on exertion, fatigue with exertion, feeling very dizzy when you exercise or take the stairs, and the reason for that, 70%, 2/3 of the people who are symptomatic with heart failure is due to obstruction, LVOT obstruction, significant LVOT obstruction or severe LV obstruction, whether arrest or by provocation. We do some things to provoke the alveoli, like exercising them. You don't have it at rest, but when you exercise and you increase your cardiac output and heart rate, you develop obstruction, more contractility, more obstruction. And about 1/3, they don't have obstruction, but they are symptomatic with heart failure. And that's usually due to diastolic heart failure. Systolic heart failure is very, very not common in hypertrophic cardiomyopathy. When your EF, as a severe systolic heart failure, when your EF drops below 50. This is an advanced, we call it end-stage disease. And when that happens, about like less than 5% of ACM people will develop that. We start thinking about advanced therapies, heart transplant, because there is no out from that other than advanced therapies. Okay, so very important number. 2/3 will have symptoms because they have obstruction, and that's the reason. That's what we have treatment for, or different treatment for. In this pie chart, what I'm showing is that people who are symptomatic in the red color, they are severely symptomatic from NYH class 3 and 4 heart failure, versus in the blue color, they are asymptomatic versus not very mildly symptomatic. And you can see here in non-obstructive disease, only 10% of them, they will have significant symptoms. 90%, they have no symptoms or very mild symptoms. And the progression of symptoms is yearly is about 1.6%, very slow progression. Versus if you have an obstruction by provocation, not at rest, they become more symptomatic. You have more people who are symptomatic, and the progression is even higher. The most symptomatic people who have rest obstruction, not with provocation, about 40% of them, they are significantly symptomatic, and 60% they are not, and the progression of symptom is higher yearly. And luckily, we have medications, interventions for that, and now we have newer medication, newer therapies in the horizon to treat that. Okay, so treatment goals. What is the treatment goals for this? We treat symptoms, and the important thing, we try to prevent complications like a tachyarrhythmia that usually happen with this pathology that lead to sudden cardiac death. And we vigorously check for these check marks or for these risk of arrhythmias for these patients, which I'm going to show in the next slides. Here is a very big review done at AHA, published at AHA basically, that shows the causes of sudden cardiac death on autopsy series of patients. You can see for people less than 35 years of age who died suddenly, they are healthy, just had a sudden cardiac death, whether they passed away from it or they came back from it. 50% is caused by hypertrophic cardiomyopathy. And then the other 50 is caused by other things, coronary anomalies, heart disease. So very common, the most common thing to have a sudden cardiac death in young people is hypertrophic cardiomyopathy. Add to that, these people are asymptomatic. So you have your athletes who play soccer, basketball, that we saw on TV, and they collapse suddenly from a sudden cardiac death, tachyarrhythmia event. Half of them, they will end up having HCM. And then when you get older, it's coronary artery disease. And this slide too, showing the mortality, causes of mortality in hypertrophic cardiomyopathy patient throughout the years, through different age values. We can see in the black bars, this is usually sudden due to tachyarrhythmia events, versus in the shaded bars is heart failure, and the plain bar is stroke. But what we can see from this slide, that at a young age, the major cause of sudden cardiac death in the young people is tachyarrhythmia, or mortality in HCM is tachyarrhythmia and sudden cardiac death. As patients age, which is a good thing, to age with this disease, that risk decreases. And now people die more from heart failure and definitely from stroke, AFib and stroke. So these, like, once you reach in the geriatric age, they tend to have a lot of AFib And we should really, really screen for that and look for AFib and try to treat and prevent stroke in these patients, which I'm going to show in different next slides. Okay. So who should we evaluate? For risk of arrhythmias or cardiac mortality or sudden cardiac death in HCM? The answer is all patients and their family members, okay? They should get evaluated for sudden cardiac death because it's asymptomatic and it can happen at any time, and there is no way to predict when or if they're gonna happen. We have a series of risk features, which I'm gonna look at, that can put them at a high risk of having a sudden cardiac event. And this done by doing echoes, doing monitors, doing imaging, mostly imaging studies on routinely, 1 year, 2 years. For family members screening who have a father who have HCM or a mother, we can do it every 3 to 5 years if they don't have the phenotype yet, and maybe more if they develop the phenotype, okay? Why we do these things? That's why. So we look for, we have a 70 years worth of data about HCM. We kind of now know risk features that increases your chance of having VT and tachyarrhythmia that leads to sudden cardiac death. And these are the risk features. This comes from the recent guideline in 2020, this algorithm. And if you are at a high risk of developing HCM, sudden cardiac death, even if you didn't have it in the past, then we talk about prevention. And what is the prevention? Putting ICDs preemptively in them, okay? What are these things? Very important to know about of course, if you have a prior sudden cardiac death, VT-VF, that buys you an ICD. But if you don't have a prior event, we look at family history of sudden cardiac death. If you have somebody in your immediate family who died suddenly at a young age, less than 40 years old, unexplained. A lot of people say they had heart attack, but you don't have heart attack at 40 years old. That kills you. Massive LVH, if your thickness is very high, 3 centimeters and above. Unexplained syncope, if you keep passing up, not from vasovagal, dehydration, orthostatic hypotension, unexplained. Cardiac syncope, apical aneurysm, EF less than 50, it means this is end-stage hypertrophic cardiomyopathy. If you put a monitor on them, that's why we put monitors in screening, and you see a lot of runs of unsustained VT, very fast, very long. And MRI. MRI, as I said, has a big prognostic value. These are abnormal muscle cells that grows and then die, cause scarring in the heart muscle, fibrosis. And if you see a lot of fibrosis on MRI, a lot of the myocardium has fibrosis that also can be a high risk for arrhythmia, VT, and sudden cardiac death. When you have these things, you start talking with the patients about getting an ICD to come to a shared decision-making, because this, we call it primary prevention, to prevent an event, the VT event. And what I'm showing here, and the ICD can be from subcutaneous to intravenous ICD. What I'm showing here is a patient that we had in the past at my prior institution, like at mentioned in the past. At age 35, he was diagnosed with HCM. He had a brother who had sudden cardiac death. They put ICD on him the year after for primary prevention. 5 years after that, he had an appropriate shock. At that time, he was sleeping when he had his VT, and the ICD kicked in and shocked him and saved his life. And then maybe 9 years after that, he had another appropriate shock when he was exercising. And we have patients like that. If they didn't have an ACD, they wouldn't end up dying. So in this slide, the annual risk when we first discovered HCM, annual mortality risk, if you carry a diagnosis of sacromeric HCM, is 6%. Very high number, okay? Now, since we started doing these family screenings, investigating risk for sudden cardiac death, like I showed earlier, putting ICDs preemptively, treating symptoms, doing heart transplantation, but the more extent is to put ICDs, prevent sudden cardiac death. We lowered this annual risk to less than 0.6%, from 6 to 0.6%. I'm showing in the second slide, although it's very, very big, we're comparing annual death in the US to from many things, from lung cancer all the way to ACM. And you can see ACM is the lowest in the group. Okay, everybody, all of us, chance of dying in the United States from diseases, from accidents is like 0.8, 0.9%, our annual risk of dying. This even went lower than that. So these things work. Screening for the disease, SCD, really, really important. That's why it should be, if you have somebody who have ACM, start the workup and send them to the cardiologist or ACM clinic, because we can preemptively, even if they are asymptomatic, they don't necessarily need to be symptomatic to prevent bad stuff in these patients. Now, exercise, a little bit talk about exercise. First, when we discovered the disease, we told the patient, you should never exercise. If you exercise, you're gonna die. You're gonna have VT and die. That has been changing since, basically. I'm showing two studies here on the left in America and on the right in Italy that showed VT can mostly happens during sleep, okay? And not necessarily exercise. Versus on the right, VT can, as I said, happens earlier in age. And as we age, less VT can happen. So you can exercise more. That's when you also need the exercise as you age. These two studies shows, randomized studies, recent, okay, showed that followed patients who have HCM for 16 weeks, who exercised mild, moderate intensity exercise versus no exercise. There's at the age group about 50, so more on the geriatric side or more on the elderly side, I would say. It really helped in their cardiac mortality, in their exercise, and their fitness, and there's no difference in arrhythmias. And the second study for patients who have HCM and diastolic dysfunction, exercise, mild, moderate intensity exercise really help their function, their symptoms, their overall mortality, and there's no difference in arrhythmia risk. Now, the young patients who are tend to have more VT, they are not been studying very well yet. So if you have an HCM phenotype and young, I saw 20-year-old the other day, 24-year-old the day after, very young patients, you have to have the conversation with them to tell them, refrain them from doing, it's not easy. You should not do, they are in college, in school, in university, and you should refrain them from doing competitive sports or high intensity exercise. This is not an easy conversation. And maybe sometimes you can tell them you should get an ICD. More studies are coming in that. Two major studies that studying young people with competitive sports who have ICDs and see if that really can be inducer for VT and sudden cardiac death. Now, heart failure symptoms. As I said, heart failure symptoms is mainly from obstruction. How do we treat that? Okay. First of all, we have to make the heart failure symptoms, we have to make the distinction. Is this from obstruction versus not? Okay, because the treatment differs. 70% of the time is going to be obstruction. So if it's, and how we do that, we do a echocardiogram, we send them to do a stress test, and if we find significant obstruction, not mild obstruction, then their symptoms is mostly from obstruction. And we have things or a lot of interventions to help with that, from medical treatment to invasive treatment. So what are the medical treatments for this? Usually we start with beta blockers. If that doesn't help, we add calcium channel blockers. Both of them, you decrease the gradients and the level of obstruction. It improves your diastolic function and it increases your exercise tolerance. But sometimes they don't work. You still have symptoms or significant resistant obstruction, or they cannot tolerate the beta blockers or calcium channel blockers due to hypotension or due to low heart rate. Then we can use other things. Disopyramide is one of them, though now since we have the newer medication, we've been using it less and less, but we have started using this medication, mavacamten, which is just got FDA approved last year in the last ACC. And it's a direct tyrosine it's a direct cardiac myosin inhibitors, really acts on the pathology. How does that work? As I showed you earlier in the pathophysiology, this is a normal patient, this is HCM patients, high sacroiliac HCM. You have a lot of cross bridges between the actin and myosin. So that results in your hypercontractility, your thickening, your obstruction. This acts directly and making them more inert. So decreases the interaction and the cross bridges between the actin and myosin. That means less contractility, less thickening, and less obstruction. That it's a negative inotropic agent that act directly at the pathology. This study that came out last year in ACC that led to FDA approval, where patients tried on this new drug, they had much more improvement in their exercise capacity and symptoms. They had less and less obstruction degree. They have less and less cardiac enzymes. And in a very small subgroup, which is very interesting, and that's going to be a focus for the years to come, it may have a remodeling effect. It can make the muscle smaller. And when they did a small subgroup MRI analysis, this yet to be determined. We have a longer term observational studies ongoing for that. We need years to really say that with certainty. One of the things that we are doing here at VCUL and elsewhere in the world. In this slide, I'm showing the improvement in the NYH classification. The blue means good. The red I would say like the purple means good. Red and blue means bad, which mean higher NYH class. And here is the mavacamten group versus placebo. As you go more weeks into mavacamten or this new medication, you see more purple, right? So more NYH class 1 or 2, less symptoms versus the placebo group. It is fairly well tolerated, this medication. And why I'm showing you this, because this is important in your practice when you're gonna see patients who are on this medication. Remember, this is a negative inotrope medication. The most common side effects for that is heart failure. It creates systolic heart failure from the negative inotropy, okay? FDA, when it's approved, this is a very controlled medication. It has to, only 5 pharmacies in the country gives it, and only through specialty centers is given. And when we give it only for 30 days, and we do an echo before we give them a refill to make sure their heart function is good, and also can help in changing the dose if the obstruction is still there. But we won't refill it until they get their echoes. Why it's important for you? Because this medication can interact with a lot of other medication, can potentiate its effect, can increase the side effects of negative inotropy and thus heart failure. So there are some medications contraindicated to be given if you are taking this medication. Mostly the inhibitors and the strong inhibitors and inducer of cytochrome P450, okay, which are like your inhibitors, your fluconazole, ketoconazole, clarithromycins, your inducer, your rifampin, seizure medication, etc. So if you have a patient, if you see a patient on mavacamten in your clinic, and you're thinking of starting an antibiotic, proton pump inhibitors like omeprazole also can be an inhibitor and potentiates its effect, versus pantoprazole is better. So discuss with the patient. I always tell the patient also, the pharmacy and our specialty clinic can help in guiding if any new medication to be added. But make him aware or reinforce that if you're adding a new medication for the stomach or for seizure or for antibiotic or antifungal, tell them that you are on this medication. Don't take it until you clear it with the pharmacy, because this may interact with it, okay? So all patients with HCM, you should really avoid dehydration with them. That worsens obstruction, or alcohol excess or excessive caffeine increases the risk of arrhythmias. Those lifestyle modification is very important. Weight loss, exercise is very important, especially in the elderly population for these people. Treatment of cardiac risk factors and preventions. You really want to be aggressive in treating their hypercholesteremia, diabetes, thyroid disease. you don't want to afford to add in an already diseased heart another cardiac pathology like heart failure or coronary artery disease that really fasten the progression of this pathology, and then send them to a cardiologist or HCM center, because really I didn't show the studies here, really it's improved their mortality and has a mortality benefits, because a lot of things you have to do early before lots of complication happens down the road, and they fail to get therapies because of the advanced disease. Okay, now if medical treatment fails quickly, what we can do invasive treatment, which is two things: septal ablation. We go in and identify a septal perforator or small artery that supplies the base of the septum, that area where it's thickened near the LVOT. We kill that artery with alcohol, kind of inducing a small myocardial infarction. It's not significant to cause any complications for the patient, but with time, once you kill the blood supply, the muscle starts to die and become thin, aneurysmal. That makes the LVOT gets bigger. Okay. Myectomy is the cornerstone of invasive treatment. The surgeon goes in, they just cut muscle, they cut beef. Okay. They can go up to 5 centimeters horizontally. They have to cut a lot. And they can fix other things if it's needed, like papillary muscle problems or mitral valve disease. As they are doing that, they can do bypass and all of that. What's the difference in mortality? It's the same. Symptoms, it's the same. The only difference between the two things is that with septal ablation, you may have more recurrence. Finally, atrial fibrillation is very common to have it, especially at high age or increased age. 20% of HCM that elderly, they will have AFib, mostly paroxysmal, okay? And AFib recurrence is unpredictable. And as I said, if they go into AFib, they don't tolerate it, HCM patients. They will have very significant symptoms from that. So we're aiming to try to keep them away by doing intervention for that. I want to show you this study. This is multiple studies that showed patients who have HCM and they have atrial fibrillation, even if not on anticoagulation, even if their CHA2DS2-VASc score is 0, their annual mortality risk is 2 to 4%, okay, from stroke and complication. HCM is making you more hypercoagulable. Add AFib to that, that makes you to have clots. So you end up having clots and maybe strokes from that. So that's why all HCM patients who have atrial fibrillation, they should be on blood thinners irregardless of their CHA2DS2-VASc score, okay? Finally, differential diagnosis of HCM. You always keep that in mind. And the LVH is hypertensive heart disease. That's the most common thing to cause hypertrophic cardiomyopathy, left ventricular hypertrophy, aortic stenosis, moderate to severe aortic stenosis, athlete hearts, infiltrative cardiac disease like amyloid, and storage metabolic diseases like Anderson, Fabry's, Danon, and Pompe. This MRI help us to, how do we differentiate between all of these? It's not a single study or one thing. It's a whole package. You have to look at the family history, their clinical symptoms, like in hypertrophy, and then you do imaging, like MRI is important. And MRI, in hypertrophic cardiomyopathy, it runs in families. You have more arrhythmias, and in MRI, you have thickening mostly in the septum with scar formation in the thickened area, versus hypertensive heart disease, more concentric thickening, less scarring, if none. And then you have a history of uncontrolled hypertension. These people, because of their uncontrolled hypertension, they will end up having chronic kidney disease and other complication related to the uncontrolled hypertension. Amyloid patients, they will have kidney disease, lots of neuropathies, and concentric thickening with a lots of scar, involve the heart as a whole, and some pericardial effusion. Storage diseases like Fabry's, mostly younger people, mostly they will have their neurological symptoms and kidney disease, and they have hypertrophy with thickness in the scar, and like a scar in the basal of the infraseptum of the heart that's distinct for Fabry's disease. In summary, I want to say hypertrophic cardiomyopathy is a very unrecognized pathology. You guys at the front of in diagnosing it, start with an EKG. If the EKG is showing LVH or they have a family history, definitely do an echo. Send them to a ACM, like to a cardiologist or ACM center specialist. Okay, we have this disease. The field is very, very advancing. If you go to all meetings, you will see like flyers about new treatments in hypertrophic cardiomyopathy. We have a lot of studies we do here at VCU and elsewhere in the States and elsewhere in the world. Many centers are involved. New therapies are coming. One therapy that just came, 2 more are coming in the horizon the next year or 2. We have also gene therapy targeting the first patients who started gene therapy a month ago in UCLA. So gene modifying, we'll see. So we have a lot of things coming on for this disease, and hopefully we may be able to cure it. Thank you very much for the opportunity. I'm glad to be here, and I welcome any questions you guys have. Thank you.
Thank you. I think we can start here. Do you guys have any questions? Yes.
Thank you so much.
One second. Can you repeat the question afterwards for the online people?
Sure.
Thank you so much, Makkiya. Quick question. So we have seen that interventions like septal ablation and arrhythmias, they increase survival and decrease risk of mortality, and of course, we relieve the obstructive symptoms. But what about the incidence of other complications of cardiomyopathy, like ventricular arrhythmias, AFib, stroke? How do these interventions impact the incidence of these other complications?
Excellent question, Ramis. Thank you very much. So Ramis is asking here, we have invasive interventions for hypertrophic cardiomyopathy, like septal reduction therapies that really helps symptoms and mortality on the long run. Does this intervention helps in decreasing the sudden cardiac death from arrhythmias or even decreases the incidence of AFib? The answer is no. These are 2 separate things. This intervention improves your mortality treating the symptoms, but not decreases your mortality because of the arrhythmias and AFib. You can always, I have patients who have myectomies at age 20 or age 40, different, or septal ablation. We still see them routinely in the clinic, and every year we see them, we assess their risk for sudden cardiac death by doing imaging studies and Holters, because this is very unpredictable. It can happen at any time in life. As you get age, it's going to be less VTs, more AFibs, and you have to keep always an eye on them. We have people who end up having ICDs and then they will end up having myectomy right after, or ICD after they get myectomy. So it really doesn't really affect your risk for arrhythmias that much. It can increase, this intervention can make you, can affect the AV node. And you can get AV nodal disease requiring pacemaker down the road, especially the alcohol septal ablation, even myectomy. So a lot of these patients who you send for a myectomy or alcohol septal ablation, they will end up with the new left bundle branch block or first degree block, second degree block, that you need to keep an eye on them.
Any questions here?
To clarify,
Yep.
some of your exercise restriction recommendations, especially for younger patients, do you individualize those recommendations based on the patient's genetics and imaging, et cetera, or is it sort of rigorous activity across the board for these younger folks?
Excellent question, Zach. So Zach is asking here, for exercise restriction in hypertrophic cardiomyopathy patients, whether young or elderly, especially young. So it's very individualized. You have to really have a very thorough conversation with them, explain the data to them, why we are trying to restrict them from strenuous activities if they have the phenotype. If they don't have the phenotype and we're just screening them because their dad or mom have the ACM, they can exercise. I don't usually restrict them until they develop the phenotype. But remember, our definition for phenotype thickness is much lower than the regular ACM patients. So if they develop the phenotype, we do all testing. Of course, if I see a lot of scarring, very thickened hearts, okay, runs of non-sustained VT on the monitor, I will be more inclined to really have a conversation to restrict them from strenuous activities. They still can do mild intensity exercises. Yes, it's not like playing sports, which we all like at that age, definitely. And some of us, and it's very important in our growth. Now, one thing, I have patients who really enjoy exercise, right? Run marathon, their septal wall thickness is like close to 3, like 2.5. But they say, this is my life. I can take the risk. I would do it. I don't care, which is very valid. Maybe if I was in their position, I would do the same, maybe not. But what is important to tell them, what's drive these arrhythmias during the exercise is the hypoxia, is the dehydration that happens, and more oxidative stress that happens with the exercise. So you want to tackle these. So you want to make sure that they are very well hydrated. Just tell them you have to hydrate very well for the exercise. Use Gatorade, electrolyte drinks. Make sure you are not dehydrated. You want to have a good warm-up, like spend some time in stretching and warm-up before doing the high-intensity exercise. So kind of you accommodate your body. So it's very, very individualized, and it's not an easy conversation. You have to throw in you have to support it by the data and show them all of that. And it depends on the person in front of you. Some patients, oh yeah, this is very risky for me, I will stop. And we see that a lot. Some patients, no, this is my life, I would continue, but I will take these recommendations.
Thank you. One last question, and then we'll stop. There's a question online. Does your hypertrophic cardiomyopathy clinic have a protocol for testing for lipoprotein A elevation and referral to a lipidologist if elevated?
So we don't typically routinely, I check their cholesterol, but these visits, when the patients come to me, and especially the first time, it's not an easy conversation. You have different age, and you're gonna give them this diagnosis. This is genetic. It has a lot of complication, and there is a lot of unknown down the road, and it's gonna be a journey. So it's gonna be a journey between me and the patients. That we need to keep an eye on it. So we talk about like a lot of things: the genetics, the exercise, the progression of the disease, treatments, and of course prevention. Prevention is a big part of that, which is hyperlipidemia. But I send them, if they are having hyperlipidemia. Usually I don't do that for them. I send them for the lipidologist to really tackle these. And it's not only lipoprotein A. Coming from imaging background, you want to look at other stuff, CRP, ApoB protein. You're going to look at the calcium score in their coronary artery disease. It's been known for patients who have hypertrophic cardiomyopathy and they have a high calcium score in their CT scan, they are more prone to coronary artery disease and more progression and lower mortality down the road. We have studies for that. So definitely, if they have uncontrolled cholesterol and it's not controllable by the medications, and you want to see them, you want to send them to a specialist to try to lower that with the newer medication that came and coming right away.
Thank you so much. Thank you, everybody.
Thank you.
Thanks for joining us. Appreciate it. The CE code will be available here if you guys want to text it in. Thank you so much.
Thank you, Christine.
Let me